So the take home is that your goal is not to eliminate pain, it is to get that patient to an acceptable level of function. You need to know with the opioids you use and the manner in which you're giving it, let's assume it's oral, that the time to peak effect is an hour. If after an hour the patient has not benefited, you're underdosing. You need to dose repeat doses by half-life. So if you order it every 6 hours, you can assume that for 3 hours that patient will have no analgesic on board. So we usually prescribe every 3 to 4 hours around the clock because that's how long the medicine lasts. And the rescue doses, the PRN doses for acute pain that isn't being handled by the steady state dose, is dosed by time to peak effect. So if someone has a pain crisis and they take a rescue dose and it hasn't done anything in an hour, they take another rescue dose in an hour. The appropriate dose of the rescue dose is about 10% of the total 24-hour opioid use. So say you have a patient taking 10 milligrams of oral morphine every 4 hours around the clock. So that's 6 doses, that's 60 milligrams. And for the most part, he's okay, but he gets an occasional pain crisis towards the end of the day, or when he gets really tired, or if he has to do something that requires unusual exertion. 10% of 60 milligrams is 6 milligrams. So since you probably can't get a pill for 5 or 6 milligrams, you may end up giving him a rescue dose of 10 milligrams or 7.5 milligrams, depending on what the pill formulation is that you can get. But that's how you estimate the amount of the rescue dose. Always document your thinking. What's the goal for the pain? What function are you trying to improve? How did you trial and error the doses? What side effects did you warn the patient about and prepare him to prevent? And what are you doing to manage those side effects? And at each visit, document the impact of both the analgesics and the approaches to managing the side effects.